Hello there everybody, hopefully you can all hear me. I'm Catherine Common, I'm the Communications Manager for Great North Care Record. We're hosting this webinar today just to talk about the trusted research environment that's one of the components of the Great North Care Record. In the phase that we're working on now, there are three parts of the programme. So we've got the Health and Care Information Exchange, we've got the patient portal, and we've also got population health management. So the trusted research environment fits within the sort of population health management. So really it was just a sort of presentation just to give you a bit of an update on some of the work that's already happened, some of the things that we're working on now, and sort of some potential things that we could be looking to in the future. The webinar today is going to be recorded and we'll be sharing a link afterwards, so if anyone's not been able to join live. And people are more than welcome, if you want to send us some questions, you can use the chat function or the Q&A function on your screen. We'll either take questions as we're going along, or we'll do them at the end. We'll sort of see how many we get. So I'll hand over to the panel to introduce themselves, and then I think Nick will be speaking first.
Right, so I'm Olly Butters. I work for Connected Health Cities. I'm part of the Data to Knowledge group at the university, and I sit more at the sort of data science end of things. I like to build tools and stuff, and that's been my involvement in this project.
I'm Nick Booth. I'm at Newcastle University as a health informatics advisor, and I'm formerly a GP and a clinical informatician. I'm the CIO of the Connected Health Cities project.
Okay, good afternoon. My name is Antony Shimmin. I work for AIMS. My involvement here is that I've been working with the Connected Health Cities group here in the North East for the past 15 months, and we are the hosting provider of the trustworthy research environment for Connected Health Cities.
And I'm Paul Burton. I'm the Professor of Data Science for Health here at the Newcastle University. I lead the Data to Knowledge research group, and I'm Principal Investigator for the University for the Connected Health Cities project. And I'm now involved within CHC, moving into, as we transition into the Great North Care Record, and I sit on the Great North Care Record Delivery Board.
Right, so we're going over to yourself, Nick, just to do your presentation.
Okay. So I'm just going to give you an overview of the Connected Health Cities project and the trusted research environment. Many of you probably already know this, but I'll just go over it very quickly. The Connected Health Cities project is a project run by the Northern Health Services Alliance, which is a consortium of universities, local authorities, trusts, AHSNs in the north of England, centred on Manchester, but distributed into 4 sub-regions. So the four sub-regions of the Connected Health Cities project are the North East and North Cumbria, which is us, Greater Manchester, the North West Coast, which is basically Lancashire, Liverpool, Cheshire and the Wirral, and Yorkshire and Humberside. So in the North East and North Cumbria, we have 3.6 million people, 8 hospital organisations, 2 mental health trusts, previously 3, now 2, approximately 400, slightly more than 400 GP practices, and at the last count, 12 local government districts. Sorry about the error on that slide. And the aim of the Connected Health Cities project in the North East and North Cumbria is to design and prototype an architecture which facilitates better frontline sharing of health and care records, to transform the way that data about health and care is collected and used in the region in health and care, and to ensure that patients and people in the North East and North Cumbria are well informed about our work through communications and participation with our projects. It's also to inform the development of the Great North Care Record. At the beginning part of the project, the teams were as one, but now have forked into 2 teams with the Connected Health Cities project, focusing on the trusted research environment, and the Great North Care Record is going into procurement for the NHS and social care. And we've funded and collaborated with projects testing aspects of the design and architecture, and that includes a trusted research environment prototype at Durham University, which Olly is going to talk about shortly, And then we are in the process of building an initial trusted research environment platform for health and care in the North East and North Cumbria. So the analytics parts of the project have been about emergency referral, transfer and discharge, and healthy new towns. That's part of the Durham prototype. Durham are going on to do work with e-observations and early warning scores, and the regional TRE is also doing work on that. And we're also have participating with us a PhD student from the computing science department at Newcastle University, who's doing a 4-year project on streaming of personal biometric data, which is analogous, in fact, to early warning score e-observations data, and predictive analytics, principally with Newcastle upon Tyne Hospital's Foundation Trust. So what is a trusted research environment? Well, basically, that's what we're going to tell you, but this is a place or a platform that you can log in to do analytics. It's also been known as the ARC. The ARC was the name in Manchester given to the data warehouse where analytics were brought together from health and social care across Greater Manchester. And the idea was to replicate that idea across the 4 sub-regions. It's also been called an ARC, spelt slightly different, and that was part of CHIE, which was the linking of an ARC and a health information exchange. A trustworthy research environment, I guess that means because it should be trusted, but we haven't done it yet, so we're not sure. And a trusted analytics platform. We expect and hope that it will be used by clinicians in primary and secondary care, and any clinicians working in the social and third sector, councils, especially social care and public health, hospital managers and designers of care, and also managers in CCGs and other healthcare organisations, by university and NHS researchers, and no doubt as time goes on by others. And so I'll hand over now to Olly, who's going to give you some more detail about what we've been doing.
So I'm going to talk a little bit about the Durham project and the work that's been done by the team over there, and then I'm going to start talking about the work that's currently going on that's been led out of the team up here. So this is a very simple, very simplistic picture of a trusted research environment. The blue box in the middle is what we would call the trusted research environment, and that's an environment that's connected to the health and social care network, and it's connected to it's hosted by AIMS, and Antony's going to give a bit of a talk about that after me, and he's got a much better picture than I have. But for the purposes of a box, this is the trusted research environment. So the Durham team, their project was around looking at historic GP attendance data to try and build a model based on the demographics of the people registered at GP surgeries and the chronic health conditions and these kind of things, to try and build a model so that they could then predict the demand for appointments at the GP surgeries. And by doing that, you can then start to ask questions like, what happens as the demography of the region changes? You know, as people get older, does a GP surgery need more appointments, for instance, or if 100 new houses get built on the edge of the estate, does that mean that how many more GP appointment slots do they need? Those kind of things. So in order to do that, the data, the GP attendance data from the GP surgeries has to be somewhere where researchers can get hold of it and do the analysis on it. And that's where the trusted research environment comes in. So in this picture, we've got the GP attendance data. So we sort of referred to this as the trusted research environment phase 1. And the way that the data has made its way from the GP attendance into the trusted research environment was via NHS mail, which is it's a secure way of moving data around, but ultimately it's email, so it's not really designed to be moving lots of data around, but it got the job done here. So the data was sent into the trusted research environment, and then the research team at Durham could then connect into the trusted research environment via a VPN connection, where they could then do the analysis on the data using the statistical software R. So that's sort of phase one of the trusted research environment, and the Durham team have very much led the development of that so far, and it's been very good. I think the project's still ongoing. Where we are now, we're starting to push forward with this and perhaps change our thinking about what a trusted research environment could work a little bit. So we've moved on, and instead of email, we can now do stuff with SFTP. So that's a much better transport mechanism to get data into the trusted research environment. So we're currently working with two trusts to look at how we can get some early warning score data into the TRE, and that early warning score data will be quite big. So email obviously isn't going to work, and SFTP is much better. And we can do this with multiple people now, so we can have different research groups getting access to different sets of the data, and with all the security wrapped up about it that Antony will talk about later. So that's kind of where we are now.
I've just got a question on VPN. Just asking, can you spell out VPN, please, all the implications?
Sure. So VPN stands for Virtual Private Network. So I don't know, Antony, whether you want to talk a little bit more about that in your section?
Yeah, sure. I'm happy to go through that.
Okay,
section.
yeah. So I'll leave Antony to go into a bit more detail about that. But ultimately, it means that it's a very secure connection. That's basically what it's there for. In terms of the development work going on in the team now, a key part of that is integration with a health information exchange. So in this diagram, we've got a health information exchange, the CHIE, in the shape in the middle. And what we've done locally is that we've got a sort of a sandboxed version of an HIE. We've been working with Tiani Spirit, and they've given us access to an instance of an HIE. We're developing ways to connect to it and push data into it and pull data out of it. So one of the projects is to connect up something that looks a bit like early warning scores, but at the minute we're just dealing with synthetic data, so made up data. It's not real data. And we're looking at how we can push that into the health information exchange, and then how we can present that back to people. So that's just showing data that's already there. It's not really doing anything particularly clever with the data. But once we can do that, we can start working on how we can pull out bulk data from a data source and pushing that into our trusted research environment. So that means that instead of doing an extract of data and pushing it in via SFTP, we can start to do these things a bit more automatically, a bit easier, a bit more routine. So it should make it easier in the future. So we're currently doing development work around this to connect things up to show that we can do it. And then the idea is that as the regional health information exchange comes online, we can start to take these lessons that we've learned with the work that we're doing here and see how we can apply those at a regional level to hopefully make it easier, and hopefully we'll just be able to copy and paste what we've done into a regional setting. Another project or another aspect of our trusted research environment is a project called Data Shield. Now it's a project, how do I want to explain this? So the Data Shield is a project that we've been developing in our group for maybe 10 years, Paul, something of that order?
Yes, 10.
It is 10 years. And the tagline of Data Shield is it's basically take the analysis to the data, not the data to the analysis. And so it's a bit of software where people can try and do, or they can do an analysis on the data, but there's built-in statistical disclosure control in such a way that an end user can never see individual level data or micro data, or however you want to describe it. There's plenty of blocks in place to stop that ever happening. And so it opens up a mechanism by which we can give access to data to people, and there's an extra layer of protection in it. So maybe we could perhaps lower the bar for how much governance we need for the data, or we can perhaps give access to data that historically we could never do because it was just too sensitive, or something like this. But it also adds a level of federation with the data analysis. So you can query multiple data sets that are in lots of different locations at the same time, and it will go off and do the analysis at all of the remote sites and then aggregate the data together for you centrally, so you don't have to try and pool it all together in the same place, which you can often not do.
I was going to say, just before we jump on, I've just had another question about the HIE and whether that's the one that's being purchased by the GNCR. So I know we just had a little chat before, didn't we, about the fact that there's the Tiani Spirit HIE, which is the sort of test version that you've done your work with. There is also the version that the GNCR has procured as well. I don't know whether anyone wants to answer the question at the moment about how the TRE will interoperate with the GNCR HIE.
I think probably maybe I should answer.
Is that something you're going to come on to later?
Well, actually thinking about it, I will answer. I can answer that in my thing at the end. I mean, the thing that we should say is that the notice about the procurement of the HIE for GNCR will be coming out next week.
Next week or so, yeah.
So then more details will be available. Yeah.
So thanks for that, Neil.
Okay, thank you. So, good afternoon, everyone. Right, so I'm going to keep my presentation relatively high level, and apologies in advance to my colleagues here who've heard me say this on a number of occasions. But just by way of introduction to AIMS, we are a spin-out of the University of Liverpool Management School. We specialise in providing solutions that solve a clinical or operational needs into the NHS, and we are predominantly a cloud and data centre service provider based out of Liverpool. Like the academic health science networks, we perceive the health sector in three verticals. The first one being the NHS itself. So we host electronic patient record systems, interoperability solutions, data management services. The second being industry. So we host applications on behalf of those who are developing on mobile phone applications or who are delivering services directly into the NHS. And the third vertical is academia. So we host services for clinical research trial units. So we're an environment where it's suitable to host data pertaining to clinical research trials. And we also host environments like the trusted research environments, which obviously we're talking about today. Needless to say, from an AIMS perspective, we adhere to all the appropriate standards and accreditations, such as ISO 27001, NHS DSP Toolkit, Cyber Essentials Plus, and we also provide access into the Health and Social Care Network, which is the N3 replacement. So we've had a strong track record in delivering services into this particular vertical, and we've been delighted to be a part of this project for quite some time. So this is sort of touching upon what Nick explained earlier, but just to give our view on all of this, through our involvement on Connected Health Cities in the Northwest, we've iteratively grown our TRE offering. So we've worked with Liverpool, Lancaster, Newcastle and Durham universities around adopting the TRE approach and refining how our end users interface with the service. The best way to think about a TRE for those who have not come across the term or are looking to get into it, as it were, is that it's an architecture that facilitates research into sensitive data. So the best way to think about the TRE is the bridge that fills the gap between academia and healthcare by providing a service that adheres to the governance of NHS and provides a mechanism by which data can be securely accessed, copied or downloaded and stored by academic colleagues or those with an interest in utilising health data for research. Whilst not exclusively for the use of academia, which is what Nick alluded to earlier, this approach allows for research to be conducted in whatever field, provided the governance is in place. It's data agnostic, so we've already heard about the various use cases that have been used to test out the TRE approach, and we're involved in a HDR UK Sprint exemplar in the field of rare diseases, for example. So again, the use cases range from population health management, clinical trials, GP service planning has been discussed, and this is very much a use case agnostic environment. Again, the tooling within the environment is very much down to the end users. Sometimes data visualization tools provided by the likes of NECS via their really impressive radar solution are useful for those conducting low-level analysis within their fields for actionable insights. Whereas some of our colleagues around here much prefer to use tools like Python and R to build their own algorithms or their own data visualizations. So this is our TRE diagram. Again, this thinking has grown and matured in recent years, and this is where we sort of are now. The best way to illustrate the TRE is within the 3 zones, and I'll go from left to right. So the interoperability provisioning zone essentially is what's connected into the health and social care network, and that's where the data predominantly sits. So you've got your GP data sitting on EMIS or TPP as an example, or you've also got secondary care data. The mechanism by which you get that data has typically been SFTP or email, but with the advances of the local health and care records exemplar program, utilising open standards such as FHIR and IHE as a means for accessing that data is becoming increasingly prevalent within this particular field. And again, we're finding increasingly that given interoperability is high on the agenda of the NHS, that vendors are getting this message, and it's making it much more easier, at least from a technical basis, to extract data from systems that typically have been locked down. The data provisioning zone, again, this is where the data lands. So if you can imagine that you've got a mechanism by which you can access this data, well, you need a place for it to be stored. And generally speaking, the technologies that are used in there are different depending on the type of data. So if you're looking at structured data, you'd use typically SQL. But if you're looking at non-structured data, you need the latest in big data technologies like Hadoop. The data of which you will put into a TRE it generally can be any data, text, images, genomic data. It's data that is sensitive and that needs to be controlled. And we've got a specific landing zone within the TRE by which data lands is located and is secure as well. Again, to the right, the analytics provisioning zone. Effectively, this is what an end user would experience when accessing the environment. And effectively what we provide are virtual desktop interfaces. They provide a window into the research environment. So if you look at this, effectively what we're providing is a walled garden approach. And I use the term data never leaves Liverpool because this is where it's hosted. But really, the data never leaves your part of the environment that exists within the data centre in Liverpool. Within the virtual desktop interface, the tooling is very much bespoke, and it all depends on what you're using. So you would find applications like Microsoft Office if you're just looking to download data into spreadsheets, or you could potentially use, as we are seeing in other projects, particularly with our AVER project in the field of mental health, we're using artificial intelligence tooling and machine learning to provide actionable insights into the fields of mental health. So the tooling is growing and developing, and generally it's all on a requirements-led basis. But again, there's anything that you can pretty much use within there. The key final point I would raise about the security within this, and this touches upon the virtual private network question, is that this is all entirely governed and audited. So access is audited to the environment. Data that goes within the environment, leaves the environment, is audited, and everything is change control managed. The end user owns the governance on this, and what we provide is a wrapper around which advises on best practice, but also adheres to governance which is set down either within the project itself or nationally. And in terms of the VPN piece, when you're accessing an environment like this, it's important that it is accessed in a secure manner. So typically what we provide is VPN access, virtual private network access, and what that effectively does is it extends a network into another physical location. So for example, with our colleagues here in Newcastle, what we've done is we've extended the TRE environment into Newcastle. So the idea being is that if you've got to be within a certain room or a certain environment to be able to access that access the service. And furthermore, the added security that we have on that is two-factor authentication. So it's not just password protected. This isn't really locked down by way of IP addressing, username and password, but also using two-factor authentication. So we use a service called Duo, where it sends either a text to your phone with a code, or it gives you a call and say, look, you're the person that needs access to this environment. So yeah, I think that's all I really wanted to cover in terms of the TRE and the approach that we've taken. And I guess if anyone has any questions, happy to answer them
I was
now.
going to say, I've got a couple of questions. I'm presuming the answer to this is yes, otherwise
Yeah.
we should be in big trouble.
Yeah.
Does this comply with GDPR standards?
Yes.
Yeah, I thought that's what I was hoping you would say.
Oh no.
Yes.
But yeah, I think it's a good. It's you know, what I mean,
We-
we've
so-
got
so-
to be compliant with this
Yeah,
stuff.
absolutely. I mean, it's a very broad question, that, but the short
Yeah.
answer is yes. You know, what I would say is that the governance of the environment is absolutely in the hands of the end users. But from our perspective, as I said, we've gone through a number of rigorous exercises, such as Cyber Essentials Plus,
Yeah.
such as NHS DSP. We were previously what's known as an N3 aggregator, which means that we were held to a certain standard to be able to provide access to data and access to systems. So we're absolutely mindful of GDPR, and we do adhere to GDPR
Yeah.
practices.
I've got another question as well. How does the data leave the environment? Can you just download just anonymised data?
Again, the short answer is it depends.
Yeah.
If you imagine, I'll give you a good example. If you're looking to access data, typically, the problem is that the systems that exist within the NHS are relatively outdated, and the mechanism for accessing that data can be quite difficult. Typically, in our experience, just because of the nature of the systems, it has been SFTP. So if you've identified the system, you have to get in touch with them to say, right, okay, I want to be able to access data. They will give you a data dump, and we would pull that data into the environment, and then we will make that data available to the relevant organisation or individual. So it's all permissions based as well. So the idea is that, you know, if there's a specific project that Paul needs to have access to, but Olly didn't, then, you know, that those permissions would be set. As I referenced before, there are emerging standards to be able to access those systems, but, you know, that's something that's going to emerge over time. But yeah, technically it's all achievable. You know, you can access the data and download it in different ways, but often it's down to the systems themselves, the source systems, and how they can provide
I
that.
presume around the governance and whatever's agreed around
Absolutely.
that use of that data.
And you've also got the fact that some of it's real-time data. So if you're looking to get real-time data from these systems, then you need to build APIs, for example. Whereas typically it's often SFTP data dumps daily, nightly, or subject to whatever governance is in place.
Cool. Right, that was all my questions. I have got another question, but I'll come back to it a bit later on.
Okay, so I'll now hand over to Paul, I guess.
Thank you. So, okay, so it's really important that up to now to recognise that what we've been talking about is the other structures that we've been prototyping under the Connected Health Cities project. What I'm now going to talk about is going forward, how this is going to segue into the design that's being considered under the a Great North Care record. This relates importantly to the question that was asked earlier on about the HIE. So the HIE that we've been talking about up to now has been a health information exchange that's been built using CHIE Spirit technology and based in the AIMS-based cloud that we've been working with that Antony's described. And that has provided us with a sandpit environment where we can test out how to try and do things in the way that Olly described, either with passing real data or with passing synthetic data to get things started in the first place. Now, going forward, we're now moving into the situation where we're talking about what's going to happen in the Great North Care record. And for the Great North Care record, this is a major regional NHS-led project, and clearly the things that we're going to be building under that have to all be identified and procured formally under NHS rules. And in fact, as I suggested earlier on, the health information exchange that we're building under that has been procured. The announcement for that is for next week.
Hopefully.
I'm sorry.
Hopefully.
Hopefully. Sorry. Okay. And therefore, there may be some differences between what is done under that compared to what has been done so far in terms of the sandpit environment. However, the basic concept that I'm now going to describe to you for the Great North Care record going forward is entirely consistent with what we've been trying to prototype within the Connected Health Cities. It just may be that some bits of what we'll do in the Great North Care record may be done in different parts of the system to what we have so far been prototyping in Connected Health Cities. So let's now turn to the Great North Care Record. And basically, as many of you will know, the Great North Care Record is a vision for an integrated health information system for the region, so the North East and North Cumbria. And one way of looking at this is that this is an aim to start building what can be called a learning health system, which is basically an integrated health system that allows you to analyse health and health-related data in an informative manner, and critically, it enables you to, once you've started getting results out from that system, it enables you to modify how you're actually dealing with your healthcare in a region, to modify what data you may be collecting. And so everything feeds back in a sort of audit cycle type situation. And the concept of a learning health system is one of the major things that's being done internationally now. It's initially led from the States in terms of how we should be dealing with our health data going forward. So let's just see what the elements of our system need to be. Now, in fact, again, as many of you will know, the funding, part of the funding of this system that we're building here is under the LICA funding from NHS England. And basically, as we go forward with that, there are 3 pillars that have been identified for what needs to become under that funding. This funding is called LICA. Those 3 pillars are, first of all, a health information exchange. And the health information exchange is a piece of sophisticated middleware that allows you to pull data from a variety of data providers, which may, for example, be healthcare trusts, could be local councils, ultimately could be general practices, but basically enables you to pull information in from those sources, integrate them together, pass them around between the different providers, and as we go forward in time, gradually we will be able to build up information on a cohort basis, so that we will have a growing cohort of those people who've been passed through the system in some way or other, have had something done to them. The information about them will gradually evolve and will be able to be part of our long-standing data information that we can then analyse. And one of the things we'll see in a minute is that, therefore, the CHIE provides one of the routes into the analysis platform. And the analysis platform is sitting at the top of the diagram that you can see at the moment in purple, and I'm going to say more about that in a minute. So the CHIE is one part of one of the pillars. Second pillar is what's called a patient portal, and the idea of the patient portal is it provides a route by which patients can either potentially access appropriate data about them, could provide appropriate data about them, and also, coming back to this question about the GDPR, going forward, one of the key issues is having a record of whether or not, or the preferences that individual patients have for how their data may be used. And again, that can come through the patient portal. One thing to recognise, which sort of is a thread that runs through everything that we're saying, is that there are 3 basic reasons why you want to collect data, health-related data, and use them to help drive your system. The first one is potentially to help drive frontline care. The second one is to be able to do strategic planning or evaluation, so actually looking at your long-term plans. And the third one is research. And basically, we need to be able to do all of those things. But initially, the focus, particularly of what we're talking about here in terms of the structures under the GNCR, that initially we'll be focusing on making sure that we're servicing the frontline care and planning, and basically as soon as we can, we'll be building in the research aspects of what we want to do. All right, now, so let's now look at the the big purple blob at the top. So basically, the first thing to say is that the term trusted research environment is exactly as defined by Antony, and an alternative name for that is the data safe haven that he mentioned as well. One of the reasons that this diagram doesn't include the word trusted research environment is that in these early phases of the GNCR, we're focusing on these three pillars that the NHS England want us to build. And in fact, the third pillar then is the population health management, both its management and the analytics that underlie it. And therefore, what we're calling our analytics platform initially is basically going to be related to a population health management analytics platform. So that basically is a trusted research environment with all the features that Antony's been describing, but nevertheless, we're not actually going to be calling it that to start with. Now, so what does that consist of? So basically, first of all, it's a cloud-based system. It'll have virtual machines that can be spun up and down on an environment which could be like the AIMS environment. And those machines allow you to set up servers that individual blocks of data can be put into and can then be analysed by the people who are allowed to use them. So once you've got one of these domains available to you on one or more of these virtual servers, then basically the precise level of security that's needed for your data will be on there. The people who are allowed to get access to will be allowed to access it via the various routes that Antony talked about. And also you will have access to the required set of analytic tools that you need. So basically each of these domains, which I like to think of as being a bit like a honeycomb, you've got all these domains sitting side by side. Each of these domains will be set up in a way that is appropriate for the data that's sitting in them and for the permissions that have been given for those data to use. And in terms of security levels, for example, that can vary, could theoretically vary, right from something being entirely open, if the data in it is completely safe, entirely open to being seen over the web as a public bit of information source, right through to the other extreme would be a set of a server somewhere that literally you're only going to be able to access that if you're prepared to go and visit a safe room somewhere and do analysis within that safe room and have your output checked to make sure that you're not actually taking anything out of the safe room that you shouldn't do. Now, those are the absolute extremes. The vast bulk of uses will fall in between those. And so, for example, a lot of these domains will be available to a small group of individuals who can come in through the systems that Olly and Antony described and do their analysis once they put in their two-factor authentication. So a lot of things will be along those lines. And then in addition, there will be the opportunity to step up that sort of control using Data Shield, for example, as Olly described. So some people will be able to log into one of these servers for a particular purpose, be able to do full analysis on the individual level data there, but they won't be able to get hold of the original, those data, they won't be able to copy them, and in addition there will be checks on the automatic computer-based checks on the information they can get out. So basically that's the overall sort of richness of the system. Now there are a number of additional things that need to be part of this in order for, you can't just have a whole set of virtual machines to properly run one of these analytics platforms. There's all sorts of additional elements that need to be in there. So one of them is on the left side of this diagram. You can see that we've got the consent. So basically, whatever the consent and preferences individuals have given for their data within these servers, those need to be properly reflected within the system. Secondly, we need data when it originally sits in any of the healthcare providers will be sitting there in a named person basis. A lot of the analysis will have to be done having de-identified those, so we'll be pseudonymizing them, and we'll be working closely with, for example, NECS the North East Commission Support Service, who basically have the right to pseudonymise data in a particular way, which will mean, for example, that if we have data coming from 2 health providers, maybe a general practice and a local council on an individual or a series of individuals, then, for example, they may have their NHS numbers will be available. We will be able to, using this pseudonymisation, will be able to ensure that the correct person is linked to their own data, but with a consistent new identifier, which can't then be identified as back to the NHS number. So basically, there's a pseudonymisation element to this. There's a whole lot of other obvious things. I'll just as 2 things I'll mention. There obviously needs to be a lot of quality assurance mechanisms in there to check for errors and to correct those errors when they're identified. And also, when data are coming from more than one source, we need to be able to make sure that those data mean the same thing. So we need to be able to harmonise data. Now, the final 2 things that I want to say are, first of all, one of the sources for data will be through the CHIE, and so there will be this gradual build-up of the longitudinal patient cohort. However, there are other sources of data, and just some examples of those will be, for example, we will almost certainly want to use research data from cohort studies, of which there are a large number of cohort studies based in the North East. And another example is that we will need information, genomic information, because a lot of healthcare activity now takes full advantage of genomic information. So basically, these sorts of information need to be fed into the analytics platform, and so there will be systems that will be doing that. These are a bit like the CHIE, but they will be going via a different route directly into the analytics platform. And then the final thing to say is that all this needs to fit in within a national framework which is being developed. And NECS, who I mentioned a few minutes ago, are centrally involved in the development of the national plans for this. And basically, one of the issues is that there's a plan for a national data lake, which will basically have what's called a persistence layer. So there will be data that will be put into that and then be available on a long-standing basis. And part of the purpose for doing that is to enable to have a consistent version of the data, which is sometimes called a single version of the truth, though I think often we prefer to use something slightly less definitive than that, because things do change over time. But the idea would be that anybody getting access to those data from the analytics platform would be able to get the same data. Anyway, a key issue of this is this particular this particular domain within the analytics platform will allow all of so NECS's work with radar will be a key element of this. So one of the ways that we'll be able to analyze and look at data for the purposes of population health management will be using NECS's radar tool. And basically, this part of the analytics platform will therefore be servicing the concept of population health management, which is this third pillar of the Leica vision for health data analysis. Okay, I think that's probably, so if we hand over to
yeah, we've got quite
now.
a few questions. I think I'll sort of, the ones that relate to what you've just been talking about. So who will govern the purple blob and ensure it's sort of adhering to security and safety of data is maintained, and assurance for the patient data who is given consent? So it's just really around the governance of how is that going to happen? How is it?
Yeah, so the governance clearly is absolutely essential here, and governance has a number of elements to it, which include the physical systems that you build in, literally maybe paper and pen based systems for some aspects of it, getting permission from committees, may have some electronic elements to it, and there clearly needs to be a group, a committee or a group that will be overseeing what happens with this. This is one of the things that is being discussed around the Great North Care record at the moment.
Yeah, so it's about bringing the members of the public into that.
And exactly, and so basically this, virtually all the discussions, in fact, all the discussions about governance around Connected Health Cities and Great North Care Record have all been subject to extensive public engagement discussions. And so we are taking account of all of these. We're taking account of things like we will need to take account of things like GDPR. There's also, in fact, another European directive coming into play in May 2020, which relates to the management of medical devices, but also includes the management of algorithms, which are fundamental to a lot of decisions in the healthcare system. So basically, we will need to do all of that. But we're at this early stage in the GNCR development. We're gradually building that together. There's no actual answer.
Yeah, well, that's it. It's the prototyping of it, isn't
Yeah.
it? We're exploring these things and working out what
Yeah.
people are, you know, what I mean, where the lines are, what, you know, what I mean, what involvement people want in it as well.
Yeah, exactly.
Obviously, we're not allowed to say the word consent, which has been said several times,
Yeah.
and people will be reprimanded for that. We do try and talk about permission, just with sort of GDPR and stuff. So, and again, we are developing a privacy preference tool so that members of the public can set their own preferences about how their data is shared. So. So that is again another element of the Connected Health Cities programme that we're working on and developing. I've got a slightly related question again, which is about sort of citizen trust. So I know we've got all the techies here, we haven't got the social people here, but you know, I mean, it is around sort of how we maintain trust, sort of in the privacy and security of this system.
Yeah. So again, this has been one of the issues that's been discussed in the public engagement work. One important thing to recognise is that so I personally come to all of this from a background of having worked in the past in the research setting in how we share and work with scientific data. But equally, there's another big block of experience that relates to what happens with health service data. And one of the important things about the Great North Care Record is that we're pulling the experiences. So as well as as interfacing directly with the public, we're also pulling experience from both of those domains, so that we're making sure that we really understand what the issues are. And the way to ensure trust, which is critical, in my view, is to make sure that you deal with all the key issues, but that you're also fully transparent with the people as you go forward. And in fact, one of the things that I think is particularly important about the Great North Care Record, which comes back to what you were saying a minute ago, is the fact that our aim at long term is to ensure that we've got explicit permissions and consents rather than relying on less specific things going forward.
Well, that's it. And again, it was definitely stuff that we explored in the public engagement exercise. And I know that Joe sort of talks about us having like the on-call anthropologist and the sociologist and the bioethicist, who are all sort of part of this programme of work, who are very much exploring that stuff. So
we're unfortunately not on call here.
No, unfortunately not this. We've got all the techies on this one. We keep it separate as much as possible. So I've got another couple of questions. I've got one about sort of voluntary sector organisations. Will they be able to work with the TRE?
Yeah, I mean the straight answer is yes. Basically, at the end of the day, any group or any body, and that means either any person or any organisation that has a justifiable reason for wanting to be able to work with data will have the potential to work with those data. And so, coming back to the question about how that'll work, about the governance, clearly, whether people will be, any individual will be able to use it or any group will be able to use it will depend on them passing the governance rules. But if you do pass the governance rules, then yes, absolutely, we're keen for people to use it. I mean, there's a general philosophy in the sort of data science world internationally that the more use you can make of data, the better you are at making efficient use of it, and therefore you get more out for your investment. So investment in the sense that the country's investing. Sorry, I don't mean
like talking about money.
No, exactly.
Keep away from that one. I've got quite a few of the questions that are coming in here. How can you control IP from research uploaded to the system?
I'm a bit concerned about me answering all the questions because I have a tendency to speak.
Are we talking intellectual property?
I don't know. I was going to say, is it? I wasn't sure if it meant IP. Like,
I'm sure it means intellectual property.
It means intellectual property.
If you can clarify that, that would be lovely.
I mean, I can say something again, but I am feeling as though I'm saying too much. Shall I say something?
Yeah.
Okay. So, all right.
The awkward question.
So,
Difficult questions to Paul.
so basically, there are two main reasons in general why data can't simply be shared around without governance. One of those is the ethical, legal governance situations that we've already talked about, but the other one is intellectual property. And so, for example, under the Data Shield project, which we say is, as we've said, is part of that, a part of this overall project, we deliberately have the potential to allow people to have their data put in a position where it can only be analysed in a way which doesn't allow the data to be taken out, taken away, seen, or anything like that.
Intellectual property.
Yes, that deals with intellectual property.
Yeah.
So basically, effectively, it is intellectual property is definitely one of the things that we know about, and it will definitely be built into the governance mechanisms that we're allowing.
And I think again, a lot of this, we haven't got this all set down in black and white. It's evolving, and we're learning it as we're going along. And it was the whole sort of point of the Connected Health Cities was to explore and trial this. We haven't got the done deal. It's not all complete, but it's what's evolving and what we're moving to in the future.
And in a sense, this webinar is neatly demonstrating this.
Yeah.
The point is, the sorts of discussion we're having in answering these questions are exactly the sorts of discussions that we need to be having and are having in terms of developing the project.
Yeah. Okay. I've got another couple of questions here. I haven't got my glasses on, which is probably not helping. With appropriate permissions in place, how do you envisage dealing with linking from other data sources, e.g. sort of diagnostic images, genomic data, to LACRA data if the longitudinal record is de-identified prior to this step? Can't say I understand that question.
No, I
do.
I do understand the question. Effectively, basically, there are domains within the analytics platform, which I'll come back to. I'll get you to say something about this in a minute, Anthony. So, in fact, actually, I'll pass it straight to you. Basically, we've got some domains that are for name data, some domains that are for pseudonymized data, and they can both exist within the platform and pass stuff around.
It's worth just go back to one of the slides. I'm not sure if we're still online. If we classify this using the data provisioning zone,
it'll come on. It just takes a second.
In the data provisioning zone, which I've illustrated, the technologies that are required to store that data are different depending on the data. So if you're looking at storing genomic data or imaging data from labs, for example, that requires different technologies. It requires Hadoop. There is a specific protocol for image data, DICOM, for example. So in terms of the domain and the permissions, from a TRE perspective, they all exist within the same environment. Logically, the permissions are different depending on what you're trying to do with them, and technically how they're stored is different depending on the data. Also, what's also worth mentioning is that sometimes it all depends on what you're doing with the data and where the data sits. So a good example of that is if you're looking at genomic data. We're working on a particular project and with health data research, and there's over 2 petabytes of genomic data within the Bioresource Centre for Rare Diseases. And sometimes it's not worth moving that data across. Sometimes you just need to grab it, store it, process it, and then throw it away. So hopefully I've answered that question in a roundabout fashion.
I couldn't have.
But the reference to interlinking with those systems, there is a push towards fire-based resources, for example, but that's very much I would argue that's more towards the hospital systems and the GP systems space when it comes to imaging data from labs. I mean, a good example is Illumina machines, which do genomic sequencing. The standards for getting data from there are slightly different. So honestly, it does depend. We've seen different ways of getting that data, both from a permissions and technology perspective. It is different. It's a very unique and bespoke field, depending on what you're wanting to do. But the environment that we've built and are growing based on use cases allows it to be like that. Be very agnostic. So hopefully that's answered the question.
Fabulous. I've got one last one. I don't know if anyone else is going to send anything through. How will advances in big data be incorporated into the TRE? Anyone fancy that one?
I'm happy to have a stab at it and then again hand over to one of my colleagues. The advances in big data, what we're talking about there is often people use the term put Google on top of your health data, and people use different terms, examples of how slow the NHS is in terms of adopting technology. The fact that you can go on Amazon and buy a book and get that delivered the same day, but you can't can't access your data. It's just they're the sort of the gaps in technology. But Amazon, Google, and other high tech companies are based upon using big data technologies like Hadoop, which allows you to do semantic searching. So if you want to build cohorts based upon a certain condition within a certain field, the ambition is that you can do, not using Google, but Google's the example that I would use, where you would access a system within this and you would say, right, okay, show me the 20 people who have got cancer within this field, and then you could get that data from the environment. Using traditional technologies, we're not necessarily there yet, but using big data technologies we can be, and that's when you can use AI tools. Again, example being Cogstack, which comes out of King's College. You can use unstructured data and be able to process that at large to be able to give you actionable insights. So the TRE accommodates that, but the TRE's advancements in technology only come with what's available. So, in 10 years' time, who knows what we're using, but the TRE's USP, as it were, is the architecture, the approach to facilitate that processing of secure data. The tooling is entirely dependent upon the data and also what you want to use it for.
So just to add to that, so effectively, as well as the need to be able to deal with large amounts of unstructured data and the development over time of the analytic things such as AI, the other thing that's critical is the governance of big data. As we know from society in general at the moment, there's a lot of issues about that, and in all honesty, we probably don't know what a lot of those are, because they're gradually evolving. So as soon as big data starts coming into this, and this includes then its analysis using AI, then that's going to have to be taken account into the governance structures that we've already talked about. And as one specific example to feed back to what we were talking about earlier on in the session, one of the key issues will be that AI is often, so will generate these algorithms. These will fall under this new European directive in terms of what you can and can't do and how you assess it. And we will need to be able to deal with all aspects of that. But again, we know that's the case.
It's coming. There's another one that I missed out earlier, which I do apologise to Phil for. It was the bit when you were showing the data shield images and the HIE stuff. And he was just saying, I'm looking at many similar project diagrams in health informatics. It feels like there's a scope for a series of project templates or series of project modules that can jumpstart new projects. Would this be useful? Yes.
I don't see why not.
Yeah, if you've got anything,
if there are similar projects, yeah, definitely.
Quite happy to take other people's work and use it as there's quite a few graphics I recognise from other sources in these slides. So we're very much about using each other's work, and if you do something better, then we're quite happy to nick it.
Yes.
I did get another one come through, just about data decommissioning, removing of data, destroying of research data from the research environment. Would trusts need to have a dedicated N3 connection to the TRE for analysing data? So we've got two questions in there.
Okay, so firstly on the data destruction piece, this is, when I say your data, it is your data. So it's entirely in the control of the data controller. So if they say to us, right, we want to remove the data from the environment, we give them the ability to do so. And furthermore, this is why we have our information security management system in place, which is ISO 27001 accredited. So we have policies and procedures in place which say, right, okay, if I want to get my data from the environment, how do I go about doing that? And how can I ensure that the data is destroyed? So we can do that, and there isn't strictly speaking a cost of doing that either. It's your data. It's your data. It's not our data. We don't. That's how I would answer that. And just remind me the second question.
The second bit was about would trusts need a dedicated N3 connection to the TRE for analysing data?
No, they wouldn't. No, I said we're in a fortunate position to be a HSCN supplier. So obviously it's the N3 replacement different network, and we've got all the appropriate accreditations to be able to deliver that access, and more importantly, we've had architectures that have been historically approved by NHS Digital as well. So we provide HSCN connectivity to a number of trusts across the country, and industry and academia as well.
Fabulous. Well, we're 1 minute from the end, so I'd say that was beautifully chaired. So if there was any what we will do, we will email everybody that's joined sort of the live broadcast, and just if you're not a member of the Discourse Network, we'll send you a joining link, just so you can keep up to date with what's happening across the programme, because obviously this is kind of one big element of what we're doing, but there are other things that are going on with Great North Care Record. I think we'll maybe stick a discussion thread on Discourse, and just if anybody's got any further questions or wants to talk about it, we can continue the conversation on Discourse as well, and we'll share the link as well for the recording. So just like to thank you all for really interesting presentations, and we'll catch up and send some follow-up information out to everyone as well. Thanks very much.
Thank you.